Right, hello everybody. Hope people are getting back from the break. So we are making a start of the next session because we have a lot of ground to cover. Thank you, Varunie, for sharing your slides already.
Okay.
Welcome to all of the speakers and everybody who's in the audience. My name is Toomse-Smith. I'm the Director of Health and Biomedical Surveys at the National Centre for Social Research, or NatCen. And in the UK, we are so lucky to have such a solid infrastructure of health surveys, including HSC, but many other surveys as well. And they keep developing and adjusting to user needs. So in this session, we are going to give you an update of what has been going on, what has been deposited at the UKDS this year, what's likely to come up. We are kicking off with Varunie Yaxley's presentation on the various health-related social service that NatCen runs. Varunie is a senior researcher at NatCen working on HSC. So over to you, Varunie.
Thanks, Mari. And hello, everybody. Good morning. So the National Centre for Social Research carries out a number of population health surveys, and the aim of this presentation is to give you an overview of what is happening with each of them. So I will give you an update on our health surveys, which are the Health Survey for England, the Scottish Health Survey, the Adult Psychiatric and Morbidity Survey, the National Study of Sexual Attitudes and Lifestyles, the Adult Oral Health Survey, the Gambling Survey for Great Britain, and the English Longitudinal Study of Ageing. NatCen also carries out the National Diet and Nutrition Survey, and this will be discussed separately today. Just to add, there will be no findings in this presentation as there isn't enough time. So starting with the Health Survey for England, which I know you've already heard a lot about, but this will just be a brief overview for anyone who is just joining. So this is a health examination survey, meaning we collect both self-reported data from participants and physical measurements and biological data. Data is collected annually and it's been running for over 30 years, and this enables us to monitor trends in the health of the nation. It's a cross-sectional survey with a fresh sample of participants selected each year, with approximately 8,000 adult and 2,000 child participants in most years. HSE 2025 is adult only, which I will cover shortly. HSE has a nationally representative sample based on the random selection of households across England. The study is commissioned by NHS England and is carried out by a collaborative team at NatCen and UCL. HSE 2024 fieldwork was completed in March 2025. We achieved 9,214 adult interviews, 1,945 child interviews, 4,966 adult health visits, 782 child health visits. Analysis and reporting is due to start on HSE 2024, with the publication and archiving the data due in early 2026. The topic reports include adult health, overweight and obesity in adults and children, adults' health-related behaviours, child health and health-related behaviours, chronic pain, social care receipt, loneliness and well-being. HSE 2025 is currently in field, and fieldwork is being conducted face-to-face with adults only. This is a decision that has been based on current budgets and child response figures. Fieldwork is due to finish in May 2026 for interviewers and June 2026 for biomedical fieldworkers. HSE includes core content each year and then additional content in some years. The core content varies year to year, and then there is additional content that is funded and added in by external funders. On this slide, you can see the core content for interviews and for biomedical visits in HSE 2025. These lists aren't exhaustive, but give an indication of the topics covered in the interview and the biomedical visits. There is no additional content in 2025. And now for an update on the Scottish Health Survey, or SHES. For anyone who is unfamiliar with the survey, SHES is a national survey about the health and lifestyle of people living in Scotland, covering both adults and children. It began in 1995 and has been conducted annually since 2008, building up a long-time series of data that is used by the Scottish Government and other parties to estimate the prevalence of health conditions, analyse the prevalence of risk factors such as physical inactivity, smoking and mental ill health, compare data for those below the national level and for subgroups such as those living in deprived areas, monitor trends in population health, such as reductions in prevalence of cigarette smoking or mental wellbeing indicators. At any given point in time, work is ongoing across several years of shares, and the current period is no exception. 2022 shares data is now available on the UK DS archive. The 2023 report was published in November 2024. Alongside this, an expanded range of survey indicators were made available on the Scottish Government dashboard. A link is shown at the bottom of the slide. And archiving is in process for 2023. 2024 fieldwork was completed in March of this year, and we're currently in the process of compiling the datasets with a report due to be published in September. 2025 fieldwork is ongoing, and we're already planning the 2026 survey. As mentioned, the 2024 survey report is due for publication in September. The main report will feature 10 chapters, including a chapter on perimenopause and menopause for the first time in Share's history. This will be reported alongside topics such as mental well-being, smoking and diet, which will include results from the Intake 24 survey based on usual intakes analysis. Along with the report, the following will also be published: tables for each chapter, a summary of the key results from each chapter, a technical report including response information and survey definitions. The survey indicators available on the Scottish Government dashboard will also be updated, meaning that around 100 indicators should be available to coincide with the report publication. The biggest change to the survey in 2025 was the introduction of the new adult physical activity module. This has been adapted from the Global Physical Activity Questionnaire to measure vigorous and moderate intensity physical activity, physical activity undertaken for recreation and leisure separately from that done for work, active travel, sedentary time, and additional question on muscle strengthening activities. In addition, the adverse childhood experiences questions have been rotated back into the adult self-completions, with 2 new questions on neglect and resilience, as well as an amended answer options in some cases to match other UK surveys. There's also an updated list of drugs in the drugs module and new questions on vitamin D and folic acid. Lastly, data from the Shares surveys undertaken between 1998 and 2020 have been linked to the health record data, with plans to add further survey years over time. This means that a wide range of survey data covering areas such as lifestyle behaviours, long-term conditions and mental well-being can be linked to data variables including hospital visits, diagnoses and treatments for specific conditions including cardiovascular disease, mortality and cause of death, and COVID test results and vaccinations. Now moving on to the Adult Psychiatric and Morbidity Survey, or APMS. APMS is a nationwide survey conducted roughly every 7 years since 1993, and it was last run in 2014. It provides high quality data on the prevalence of trends in mental health in England and is commissioned by NHS England and sponsored by the Department of Health and Social Care. It is run by NatSen in collaboration with the University of Leicester and City St George's, University London. Fieldwork for APMS included a 2-stage design. Participants had an initial interview with the survey questionnaire, including a self-completion component, and then a subsample were followed up with a clinical assessment by University of Leicester interviewers. Here is an overview of the content covered in the main interview visit, which took around 90 minutes on average, with initial CAPI questions followed by self-completion for more sensitive topics, and then a final section of CAPI questions. The Phase 2 clinical assessment covered psychosis, autism, and eating disorders. Phase 1 of the fieldwork was completed in April 2024, and Phase 2 in July 2024. The report will be published in 2 parts. Part 1 is scheduled to be published this coming Thursday, so please look out for it. This will include 6 substantive chapters and the methods documentation. Part 2 is due to be published in the autumn. We aim to archive the data for other researchers to use at the same time in the UK DS archive by February 2026. So moving on to the National Study of Sexual Attitudes and Lifestyles, or NatSal. NatSal is a representative biobehavioural survey of the general population in Great Britain. NatSal was first carried out in 1990 in response to the HIV/AIDS epidemic. Since then, it's been carried out approximately once every 10 years and provides high-quality information about sexual behaviour, attitudes, outcomes, and service use, among other topics. This slide gives you some top-level information about the data collection for the fourth NatSal survey. Data collection started in September 2022 and finished in April 2024. There are 3 data collection arms, 2 probability runs by NatSen and 1 non-probability arm run by Ipsos. The sampling for the first probability arm was a postcode address file. The sampling frame for the probability arm was the NatSen, for the second probability arm was the NatSen opinion panel, and the sampling frame for the non-probability arm included the Ipsos panel and the external online panels. You can see the number of participants in each arm, modes of data collection used in each, response rates for each probability arm, the age range of the participants, and whether the arm included a young person's boost or an ethnic minority boost. The total number of participants who took part in NatSal-4 was 18,987, approximately 1/3 of which took part in the probability arm. The NatSal team are currently analysing the data and writing a range of academic papers for publication early next year. Alongside this, the team are progressing well with applications for data linkage. The aim is to publish the first tranche of peer-reviewed papers in early 2026, and a second tranche of papers will follow after that. The data will be archived in November 2026 for other researchers to use both in the UKDS archive and in the ONS Integrated Data Service. The NatSal-4 grant ends that month. We'll now move on to the Adult Oral Health Survey, or AOHS. AOHS provides up-to-date surveillance information on adult oral health status, oral health inequalities, oral health-related quality of life, and oral health behaviours. It's been conducted roughly every 10 years since 1968. The 2023 survey is covering England only, and it's funded by the Office for Health Improvement and Disparities and the Department of Health and Social Care. The consortium is made up of NatSen, ONS, and academic partners. The survey involved selected a random probability sample of addresses across England only, and this was drawn from Addressbase. The survey design involved a paired visit for the first time, with interviewers and dental examiners visiting the households together. Up to 2 adults aged 16 and over per household could take part. Fieldwork took place from June 2023 to April 2024. The interview consists of 2 parts. The interviewer administers the household questionnaire, individual questions on health and lifestyle, oral health behaviour, as well as scales, including the modified dental anxiety scale and the oral impact of dental problem scale. The examiner conducts a 20-minute examination of mouth, teeth, and gums. Examiners look at the health of intraoral soft tissues, presence of dentures, tooth condition, tooth wear, and root condition. The final report is due to be published on the Office of Health Disparities website, and the data will be available at the UKDS archive in the autumn of this year. The next survey is the Gambling Survey of Great Britain, or GSGB. GSGB collects data on gambling behaviours among adults in Great Britain. Gambling is increasingly seen as a public health issue because it can cause addiction and have significant impact on mental health. The aim of the survey is to measure gambling participation and prevalence of problem gambling. It is a push-to-web methodology aiming for an annual sample of 20,000 adults. It is funded by the Gambling Commission and carried out by the National Centre for Social Research in collaboration with Heather Wardle at the University of Glasgow. The report is published annually with interim quarterly reports as well. Looking at upcoming and recent reports, Year 1 annual report was published on the 25th of July, and the Year 2 annual report will be published in October 2025. And finally, the English Longitudinal Study of Ageing, or ELSA, is another health study we carry out at NatSem. ELSA is a population cohort study of adults aged 50 plus and their partners living in England that started in 2002. The study interviews the same group of people every 2 years, and the sample is refreshed often to ensure that it remains representative. Wave 10 and 11 also included an ethnic boost. The study's overall aim is to provide an understanding of the dynamics of ageing as people move into retirement and into old age. The context of the study is one of huge demographic change in terms of an ageing population. This is something to be celebrated in terms of the impact of improving health and social care, education, living standards, and so on, but also raises social and economic challenges. ELSA aims to understand these challenges as well as the contribution that older people make to their families and our society. The study is multidisciplinary, so it covers every aspect of a person's life and aims to understand the relationship between people's health and their economic and social circumstances, and how these things interact as people age. Every few years, including the wave in field currently, participants are invited to a health visit which collects a range of biomeasures, which the participants receive results from. In the latest wave, we carried out 7,842 interviews, 65% of which completed a health visit. ELSA is carried out by NatSen in collaboration with the University College London, the Institute for Fiscal Studies, the University of Manchester, and the University of East Anglia. ELSA is commissioned by an American organisation called the National Institute of Aging, who fund the health and retirement study in the US. It's also funded by various government departments, including the Department of Work and Pensions, the Department for Transport, and the Department for Health and Social Care. And there's also some funding from the Economic and Social Research Council. This slide shows the progress on different ELSA waves and sub-studies. At the end of each wave, the data is uploaded to the UKDS archive for researchers to access. A report is produced at the end of each wave with a summary of results. We recently archived the data for the HCAP2 sub-study for Wave 11, and these datasets are now available on the UKDS archive. We're planning to archive the data for Wave 11 health visit and for the life history sub-study in the late summer and autumn, respectively. We're currently preparing to start fieldwork for Wave 12 pilot study, which will be the first ELSA wave with a web-first mixed mode design. This slide shows the topics that were covered in the Wave 11 interview and the new questions that we added for this wave. The majority of the interviews were carried out face-to-face, with less than 2% carried out via video interview. Respondents were also asked to complete a paper questionnaire on sensitive topics and a health visit, including blood pressure and samples, grip strength, height and weight, balance, leg raises, leg function, and a hair sample. Thank you for listening.
So we're going to move on to our next presentation, which is by Dhriti Mandalia. So National Diet and Nutrition Survey has been undergoing a lot of change. It's been redesigned over the past couple of years, and Dhriti will give you an overview of what these changes are and what you can expect in terms of data. Dhriti is a senior researcher at NatSen, and she works on NDNS and also the Adult Oral Health Survey. So over to you, Dhriti.
Hello everyone. So today I will be introducing the redesigned National Diet and Nutrition Survey, or NDNS as we call it. I'll provide some background to the survey and explain a little bit about the rationale for adopting a redesigned fieldwork model. I'll also give an overview of the survey content and its various features and tell you how you can access the latest published report and the data. Okay, so firstly, some background about NDNS for those of you who may not know the survey. So the NDNS is a cross-sectional survey designed to assess the diet, nutrient intake and nutritional status of the general UK population. So it's carried out on behalf of the Department of Health and Social Care and the Food Standards Agency, and we work on behalf of the Office for Health Improvement and Disparities. It's the government's only source of high quality, nationally representative data on the types and quantities of foods consumed by individuals. And the data is used by UK governments to monitor progress towards achieving diet and nutrition objectives. So, for example, to track progress against targets on salt intake and saturated fat, to monitor advancements in diet and nutrition objectives, and to estimate the presence of compounds added to foods such as preservatives, colorings and flavorings. So it's quite a high profile national survey that we run. So historically, the NDNS has been carried out as a face-to-face interviewer-led survey. So if we just look at this model in a bit more detail. So it begins with a letter sent out to randomly selected households. These are then followed up by an in-person visit from a trained interviewer who will introduce the survey, gain cooperation and select individuals to take part. And during this visit, the interviewer collects background data about the household and then conducts individual interviews. And these involve the participant completing a food record via Intake 24, and more on this a bit later. And this is done with the interviewer's assistance, and it's a record of everything that the respondent has eaten and drunk using this online tool. A spot urine sample is collected as part of the home visit, as well as height and weight measurements. And participants are also asked to consent to a follow-up visit from a biomedical field worker who will collect a blood sample. So this is the traditional historic NDNS fieldwork model. So why have we moved away from this fieldwork model? So over time, several challenges have made face-to-face fieldwork increasingly difficult, not just for NDNS. These include declining response rates, growing survey fatigue, and a limited pool of experienced interviewers. So as a result, it's become essential to reassess our approach to survey delivery to ensure it remains sustainable, efficient, and fit for the future. So what does this redesigned model look like for NDNS? So firstly, as you can see from this slide, the face-to-face interviewer visit has been completely removed. So households still receive an initial invitation letter as they did before, but they're asked to self-select individuals to complete a short online survey. The selection of participants for NDNS actually depends on two different sample types we have. So we have something called basic addresses, and in these addresses, it's typically 2 adults and 1 child. And then in young person addresses, it's up to 2 children aged 1 to 18. There's actually an option for respondents who may not be technologically savvy to complete the survey with telephone assistance if that's required. The first food record is completed as part of the online questionnaire, and invitations via text or email for subsequent food records are sent to participants on randomly assigned days over a 2-week period. And after completing the first food record, participants are asked if they would be willing to provide a self-collected spot urine sample this time. And the way that this works is that a kit is sent to their home, and this is triggered by the online survey. And then instead of collecting physical height and weight measurements, we ask respondents to self-report their height and weight measurements in the online questionnaire. And there's consent to data linkage as well. For those who agree to contact, a biomedical field worker will arrange an appointment to conduct the second stage, as in the previous model, to do home visits to collect some measurements and a blood sample. So future-proofing a large-scale complex survey has resulted in several significant improvements. Firstly, it's now more cost-effective as we have eliminated the need for face-to-face visits by interviewers. We've also increased the scale of the survey, issuing over 70,000 addresses to achieve a target of 4,000 interviews instead of the previous target of 1,000. The new design is adaptive, allowing us to add sub-studies in various survey years. So, for example, there's future plans to do a sodium study, and this will allow us to gather more comprehensive data. Additionally, we can produce reports more promptly, with annual reports on diet and biannual reports on blood, compared to the previous frequency of every 2 to 4 years. And moreover, the redesigned model offers greater scope and flexibility for expanded reporting on specific subgroups within the population, key nutrient markers, and relevant policy areas. So now looking at the content of the questionnaire. So there was a development phase that we conducted where we streamlined and adapted the face-to-face questionnaire for mixed method data collection involving the online survey and telephone assistance. So this new adapted questionnaire is split into 2 parts. So part 1 includes questions about the household, eating out, food avoidance, food security, income, and collects agreement for a biomedical field worker to make contact for stage 2. Part 2 includes a few more questions on general health, self-reported height and weight, and agreement from those aged 4 and over to provide a self-collected spot urine sample, which is measured for iodine status. The survey also includes key demographic questions such as age, sex, income, ethnicity, working status, and educational attainment. And I just want to point out here that this new newly designed model is a baseline survey. It's not comparable to previous face-to-face models that the NDNS is used to because of the comparability between the different modes. Also, as part of the survey, participants are guided to an external platform called Intake 24, where they complete their first food record. This is introduced at the end of the part 1 of the questionnaire. So Intake 24 features a built-in food database with linked portion sizes and nutrient composition data, enabling automatic calculation of dietary intake. Once the initial food record is completed, participants can seamlessly return to the main survey to complete the remaining sections. Participants are then invited via text or email to complete up to 3 additional food records scheduled at randomly allocated days of the week. And after completing all food records, participants receive personalised dietary feedback based on their entries and a £20 incentive. So a £10 incentive is offered at the end of part 1 of the questionnaire and completing 1 food record. And then an additional £10 is offered after submitting all food records. The second stage involves a visit from a biomedical field worker. So participants, as I mentioned, participants are asked at the end of stage 1 whether they would agree for a biomedical field worker to make contact to introduce the survey and explain in detail what the second stage involves. If they have agreed, the biomedical field worker will arrange an appointment to carry out the visit. And this involves collecting data on current prescribed medications. They take an infant length measurement from children aged 12 to 23 months and collect an e-consent to take a venous blood sample from respondents. And if the participant is aged 11 and over, this will be a fasting sample, but if they're aged between 1 and 10, this will be a non-fasting sample. And on NDNS, blood is analysed for various nutritional markers such as vitamin D, ferritin, vitamin B6, and vitamin C. And participants can choose to have their results sent to them if they wish. So now looking at data access and published reports. The latest combined report on years 12 to 15 was published on the 11th of June, and I believe that was last week. And it's available on the DHSC's website. There will also be a Northern Ireland report covering years 10 to 15. Publication for this report hasn't yet been confirmed, but it's likely to be late autumn this year, so watch this space. And data will be available via UKDS's website. And just to give you some an update on where we are at this present time with the surveys. So we have just completed fieldwork for year 16, which is the first round of this newly redesigned fieldwork model in May 2025. So this was a compressed year, meaning that the sample was issued over a 6-month fieldwork period rather than over 12 months. And we are now preparing to launch year 17, which will go live on the 1st of July. And the sample for this will be issued over a 12-month period with data collection continuing till July next year. So the next published report for NDNS will be year 16 to 17 combined and will cover the diet and biomarker data. We're probably looking at summer 2027 for the release of the data, given that year 17 hasn't actually started yet. And finally, it's also worth mentioning that besides the data made publicly available on UKDS's data archive, there's also the NDNS bioresource. So the biorepository is an archive of biological samples collected from various surveys, including NDNS 2008 onwards, the Diet and Nutrition Survey of Infants and Young Children 2011, the urinary sodium surveys from 2001 to 2005 for England, Scotland and Northern Ireland, and obviously previous NDNS surveys from the 1990s to the 2000s. These collected samples are stored for future research, and access to the NDNS bioresource is via a formal application to the NDNS bioresource panel, and the link is on the slide just there. And that comes to the end of my presentation. So if you do have any burning questions that I've been able to answer in this session, you can contact the NDNS research team using the email address on screen.
And moving on to longitudinal studies now. So next up we have Richard Silverwood from UCL, who will tell us about what has been going on with health data in the CLS National Longitudinal Cohort Studies. Richard is Associate Professor of Statistics and Chief Statistician at the UCL Centre for Longitudinal Studies. So I'm going to hand over to you, Richard.
Thank you very much. Hopefully you can see the slides and hear me okay. There's quite a lot to talk about today because as usual, we've been very busy, so I'll have to skip through things pretty quickly. But there's lots of information available on the CLS website if you're after more information after this. So first of all, just very quickly, what do we do at CLS? So we're an ESRC funded resource centre based at UCL. We run a series of nationally representative UK cohort studies. So we've got 4 core cohort studies that I'm going to talk about today or mainly focus on, and then 3 newer studies that I will mention only briefly at the end. So really the importance of these studies is that we're generally following individuals from birth in the majority of our studies right the way through their lives as they're naturally going about living their lives. And these give us very powerful sources of data for answering important research questions. Because we're running these studies ourselves, we're interested in questions about survey methodology. So we conduct our own survey methodological research, and because we're analysing the data ourselves and because we want to support data users to analyse the data in the best way possible, we also conduct some statistical methodological research, which I lead on. This slide just puts the cohort studies in context. So the 4 core studies are the 4 in the middle here that I'm going to focus on today. So that's the National Child Development Study, born in 1958, the 1970 British Cohort Study, born in 1970, Next Steps, born in 1989 and 1990, and the Millennium Cohort Study, born in 2000. On the left-hand side, there's the National Survey of Health and Development, born in 1946, which is run by colleagues also at UCL in the Unit for Lifelong Health and Aging, who we collaborate with closely. And on the right-hand side, one of the newer studies there, the Early Life Cohort Feasibility Study that I'll mention briefly later on. So these are the 4 core cohort studies. The National Child Development Study is all births born in 1 week in 1958 across Great Britain, who've been followed since birth. The British Cohort Study follows a similar design, so it's all births in 1 week in 1970, followed from birth onwards. I'll come back to Next Steps because it's a bit different. And the Millennium Cohort Study is a sample of births across all of the UK in 2000 to 2002, again followed from birth. And as I say, Next Steps is a little different in design. So the cohort members were only recruited when they were in year 9 at school, so age 13 to 14, and they've been followed up from that point onwards. And that study is for England only, or pupils of English schools at that point only. So each of these studies are of sample size or 16 to 20,000 at initiation. This slide shows the progression of these studies over age and over time. The dots show the points in time at which we've collected data. So you can see for the majority of studies, these are fairly evenly spaced and they start at birth. So we have follow-up data collections around every 5 or so years. But for Next Steps, there's no data collections, as I say, until age 13, 14. Then there's a cluster of annual surveys there. And at that point, the study was actually run by the Department for Education. We only took over later on. And then they're a similar sort of sequence as we see in the rest of the CLS cohorts. So the focus today is on health, but here's a bit of information on the typical information covered across the various domains that you would expect in this sort of general study. So across health, social, and economic domains. The information that we collect is generally similar across the cohorts, but obviously as time progresses, some things become more or less of interest. And some of these things, such as physical measurements, physical health, mental health and well-being, cognition, are monitored at numerous points across the cohort, across the life course within cohorts, so we can construct trajectories of those over time. These are the core data collections over the last few years, going slightly into the future. I'm going to concentrate on these ones in the grey boxes, which are the recent data collections. The one here at the bottom for the NCDS was interrupted due to the pandemic and delayed slightly, so only completed quite recently. The BCS one, age 51 to 53, has finished recently as well. Next steps at age 32, finished recently. For all of those three, the data are either available already or will be in the next few weeks. And then the Millennium Cohort study at age 23, the data collection is now finished and we're just processing those and getting ready for the deposit of the data. The two, sorry, my video is over the top of it, but the two on the right-hand side, so BCS at age 56 and NCDS at age 68, are planned web-only data collections, a joint data collection across those two studies, which is planned to take place next year. Excuse me. So the next few slides, I'm just going to focus on the health data that we've collected in these most recent suites of these core studies. And you'll see that across the different studies, we're collecting information on some fairly similar topics, but then there's some extra ones that are more kind of age specific. So in next steps at age 32, you can see we're collecting information on sort of general long-standing health problems, a lot on health behaviors, a special module on COVID-19, and then some additional information on pregnancy history, fertility treatments, etc. Importantly here, we've also collected saliva samples, which has given us genetic information in this cohort for the first time. And I'll come back and discuss that later on. And as noted at the top, these data are available now from UKDS. BCS 70, age 51 to 53. Health data, again, these are available now. Similar sorts of topics that have been covered. Again, this is just a focus on the health data. Lots of broader information available there in the data deposit. The health data in the most recent NCDS data collection, so ages 61 to 65, come from a couple of different sources. So there's this shown on this slide here, information that have come from the survey component, and then on the next slide I'll show a couple of additional components where there's some further information. So again, you can see here we're covering similar sorts of topic, and part of that's by design to allow us obviously to make comparisons between these different studies. So in addition to the survey information on the previous slide, we get some additional information in this most recent NCDS suite. Firstly, from the nurse visit, which provide a number of biomeasures on prescribed medication, blood pressure, grip strength, some other measurements, standing balance, timed normal walk, measurements on anthropometry that are objectively measured in this case, and then importantly, some blood samples that allow us to analyze for biomarkers and again, some genetic information. So I'll cover the biomarkers separately over the next couple of slides. There's also an online diet questionnaire that covered, I think, 2 days randomly selected from the 7 days following the nurse visit, which I won't go into the details of, but standard online diet questionnaire with lots of information available. So this biomedical data collection at NCDS age 61 really complements a couple of similar data collections we've had, one earlier in NCDS at age 44 to 45, one at a similar age in BCS 70. So this obviously provides some research opportunities, so you can use a single time point and lots of interesting things that you can do there. But now also you can make between cohort comparisons at similar ages, longitudinal comparisons within NCDS. So these are some of the biomarkers that we've observed across these three biomedical data collections. So some of them have been observed in all three of these studies, some of the important factors there, and some not in all of them may still be of interest. And then I think importantly in the most recent NCDS sweep, you can see at the bottom there that we've added some metabolomic biomarkers. So again, I've not gone into the details here, but there's loads more information on all the metabolites that we've analysed elsewhere. In addition to the survey data that we collect, we've had a sort of intensive program of linkage of administrative health data at CLS. So in England, we've linked all four of these the core cohorts into hospital episode statistics. These data are available from UKDS. In Scotland, we've linked the health records into all of the cohorts where relevant. So because Next Steps is England only, obviously we don't have any Scottish health records there. Again, available from UKDS. And in Wales, we've got linkage for MCS available either via the SAIL data bank and increasingly now also via UKDS. And finally, to note that we do also have all our data on the UK longitudinal linkage collaboration. And this also includes linkage to health records, and increasingly, I think, over the next few years, it's going to include linkages to other kind of non-health related administrative data too. A real strength that we have in our cohorts is the availability of genetic data. So this has been available for NCDS, BCS 70 and MCS for some time. And the recent addition is also having genetic information available for Next Steps. So the screen grab I've got here is a new website that's been developed with the link at the bottom there, which gives loads of information about the data availability, the process for applying for data, which has been recently streamlined, and lots of information about the analyses that are being conducted and all the QC that's been done. A major program of work within this at the moment is deriving and then making available for research purposes the polygenic scores, or polygenic risk scores, or polygenic indices as they're called elsewhere. So some of these are already available via the CLS Data Access Committee, but the big launch is going to be next year when we launch on UKDS a whole suite of these polygenic scores across multiple health and social phenotypes. I won't dwell on this too much because the data are a few years old now, so you may well know about this already, but during COVID, we did have 3 sweeps of data collection across our 4 core CLS cohorts, plus the NSHD born in 1946, as I mentioned earlier. Respondents to any one or more of these surveys also took part in a serology study. Similar serology study used across several other sort of longitudinal population studies. So there's lots of opportunity, and in fact, lots of research has already been conducted across multiple different cohorts and other studies using these data. And finally, I just wanted to note 3 additional cohorts that we're involved in at CLS. We're either running these potentially in collaboration with others, or have some other involvement in them. So the first one is a study I've been working on myself a lot over the last couple of years, the early life cohort feasibility study. So this has been selecting a nationally representative UK-wide sample of births. The main idea is testing the feasibility of a number of different approaches to potentially use in a larger study, so that approaches around the data, the sampling frame, the data collection, incentives, data linkage consents. But we have collected data on around 2,000 families, babies born in 2022. So the data will be of interest for research purposes. These will be available soon via the UKDS. We're just preparing those for deposit now. The second one is the children of the 2020s. This is a nationally representative birth cohort study of babies from around 8,500 families born in 2021. Focus on family, early education and childcare determinants of early school success, using some innovative approaches, particularly to data collection using an app that the parents use. And the Wave 1 data from when the children are 9 months old are available, though in this instance via the ONS Secure Research Service. And then there will be subsequent waves with data available soon. And finally, I wanted to mention the COVID Social Mobility and Opportunities, or COSMO study. It's a cohort study of over 12,000 students in England who are in year 11 in 2020 and 21, including information from their parents. So the idea here is exploring disruption to schooling during the pandemic, which obviously can have serious and long-lasting implications, with a particular focus on investigating whether the already entrenched inequalities that we observe are further exacerbated by the pandemic. And Wave 1 and Wave 2 data are already available via UKDS. And then finally, I just wanted to plug this 1-hour webinar that we have coming up next month on the 17th of July, which is giving a proper introduction to the new data that we have at age 62 in NCDS. So the link is there, or if you just go to the CLS website, click on events at the top, you should find it very quickly. And that's me. Thank you.
So next up, we have Jemima Stockton, and she will give us an update on the UK census-based longitudinal studies. So Jemima is a research associate in the Department of Epidemiology and Public Health at University College London. So Jemima, are you able to share?
Yeah, I'm just trying to do that now.
No pressure.
Can you see it now?
I can see your screen. So if you go,
okay, yeah, just go to from beginning. Okay, can you see it? Is that good? Okay,
yes,
great.
That's all good.
Okay.
Over to you.
Okay, so this presentation is to tell you about updates to the UK longitudinal studies, but as not everyone's familiar with all or even any of the UK longitudinal studies, I'll give a brief introduction to them first, and the updates I'll provide will relate mainly to the data added from the latest censuses. And as I'm presenting today in my capacity as a user support officer with UCL's Centre for Longitudinal Study Information and User Support, which helps academic researchers who want to use one particular one of the 3 longitudinal studies. The focus will be on that one, although I will cover all 3 longitudinal studies. So first I'll explain what the UK longitudinal studies are, and then I'll give an overview of each longitudinal study, and then I'll give updates on them in terms of the newest data added, what the newest data shows, and when the newest data will be available to researchers. So the UK longitudinal studies are based on the UK censuses and contain linked census and life events data for proportions of the population of the 3 jurisdictions of the United Kingdom, namely England and Wales, Scotland and Northern Ireland. And they're separate because each jurisdiction administers its own census. So the England and Wales census and longitudinal study are administered by the Office for National Statistics, which is the executive office of the UK Statistics Authority, reporting directly to UK Parliament. The census of Scotland and its longitudinal study are administered by the National Records of Scotland, which is a non-ministerial department of the Scottish Government. And the Northern Ireland census and longitudinal study are administered by the Northern Ireland Statistics and Research Agency, or NISRA, which is an executive agency of the Department of Finance in Northern Ireland. So statistics are produced by the national statistics agencies of all 3 jurisdictions, and then they're overseen by the UK Statistics Authority. So censuses of the general population of the 3 jurisdictions in the UK started in 1801 and have taken place around every 10 years since. But a primary purpose of these decennial censuses to guide the calculation of resource allocation across areas has remained, but the data has grown in complexities, which gives a richer population profile snapshot, which is really good for researchers. So the first of the UK census-based longitudinal studies in England and Wales was instigated in 1971, specifically to provide a means of investigating the longitudinal relationships between occupation and mortality and between socioeconomic characteristics and family formation. But since then, the range of topics investigated has grown massively. So in my role, I work specifically with the Office for National Statistics, LS, of England and Wales, which, as I mentioned, was the first LS to be started. And I'll now provide an overview of that. So the ONS LS contains linked census and life events data for a 1% sample of England and Wales, with individuals becoming members if they have 1 of 4 undisclosed birthdays. So 4 out of 365, which is about 1%. And their census forms have been linked from 1971 right up until 2021. And the last census was on the 21st of March in England and Wales. And despite taking place during a national lockdown, its overall response rate was 97%, with all local authorities above 88%. And there was a huge increase in the proportion of online responses, with 89% being online compared to only 17% in 2011. And it's a census the latest census to be linked to the ONS-LS, and it took a while because it's a big job, and was completed only at the beginning of this year. And although application to use the LS is open to everyone, the latest release isn't yet public because the linkage hasn't been fully tested. And some of the work I'm presenting here is based on, is a part of a beta project, which is one of 9 being undertaken in the UK to test the integrity of the 2021 linkage. So the data relating to this is provisional. So this slide illustrates the dynamic nature of the longitudinal study, and it shows the samples at each census and the numbers of entry and exit events over the course of the study. And it also shows the number of other linked live events, namely live births to sample mothers, stillbirths to sample mothers, widowerhoods, infant deaths and registrations. But again, we need to remember that the numbers for the 2021 census and the linked events are provisional as they're drawn from beta testing. So since the inception of the ONS-LS, data has been captured from census questions on marital status and family type, housing and amenities, occupation and social class, economic activity, education, migration and ethnicity, as well as geographies to which area level data can be added. And researchers are given access to the geographies down to local authority level, but if they want to attach area level data at any lower level geographies, such as output areas, the linkage has to be done by ONS because researchers aren't allowed to see, for example, the specific output areas associated with LS members. And new topics have been added in successive censuses. So in 1991, new topics of travel to work and long-term illness were added. In 2001, there were questions on religion, self-rated health and caregiving, and information on passports held and national identity and time since arrival in the UK were collected in 2011. And most recently in 2021, new questions appeared on sexuality, gender identity and service in the UK Armed Forces. So the range of topics has grown, which provides more opportunity for research. And obviously the topics introduced for the first time in 2021 can't yet be examined longitudinally in the ONS-LS, but those asked for the first time in 2011 can be. And the census information collected on health outcomes is quite limited in the ONS, highlighted here in yellow, namely long-term illness and self-rated health. But all census-derived ONS-LS topics listed have been studied in relation to health. And for our beta project, we're interested in the changes in travel to work, particularly the retention and uptake of active travel, so walking and cycling, which has both direct and indirect impacts on health through physical activity and air pollution, for example. And we've found that this topic has been impacted by COVID, which was in full swing at the time of the 2021 census. So many people were furloughed and they were asked to report their usual mode of travel to work for being furloughed in the 2021 form. And those that weren't furloughed were impacted, at least to some extent, by travel restrictions, as evidenced when we compared the mode transitions between 2001 and 2011 with mode transitions between 2011 and 2021. So in this cross-tabulation of mode in 2001 by 2011, the dark blue cells indicate the most prevalent mode in outcome in 2011, and the light blue, the second most prevalent. And if you look along the diagonal, you can see that for only 2 passengers, train passengers and car drivers in 2021, the retaining their mode in 2011 was the most prevalent outcome. But for all other modes, switching to car driving in 2011 is the most common outcome, and retaining them is only the second most common outcome. And you can see here at the bottom the retention rate for walking and for cycling are 35 and 30% respectively. So quite low. And when we look at mode transition from 2011 to 2021, with a cross-tabulation of mode in 2011 by mode in 2021, we can see now that for all modes, including tube and train in 2011, a shift to car driving in 2021 is the most prevalent outcome, probably reflecting the reduction in and restrictions on use of public transport during the COVID pandemic. Next, we plan to look at cancer and mortality outcomes in relation to travel to work, which are kind of events data. So, and the next slide is about events data. So, what events information does it contain? In contrast to the census information, which has been expanding, the events data topics haven't changed. Events data for LS members resident in England and Wales is linked to the LS from the civil registration system, the NHS Central Register and cancer registries, namely the National Cancer Registration and Analysis Service for England and the Welsh Cancer and Intelligence and Surveillance Unit for Wales. And events are added annually and comprise deaths, cancer registrations, births, immigrations, widowhoods and infant deaths to sample mothers, stillbirths to sample mothers and live births to sample mothers. And there are actually two ways by which events data is linked to the other records in the LS database. So all LS members are flagged in the NHS Central Register, which is the database of people who've ever registered with the GP in England and Wales. And any death, cancer registration or GP registration or deregistration, which is indicative of immigration and emigration of LS birth dates, are then automatically sent to the ONS LS team to be added to the ONS LS. All other events for people with LS birth dates are searched for annually by the in the various registers and then matched if the person exists in the LS. So this means that deaths and cancer registrations are captured by both flagging and kind of active searching, making the linkage rates very good for them. And although data is added annually, there's a lag of 2 years in the kind of up-to-dateness of the data. Yeah, events data has been used in many studies. For example, this study by Joanna Davies and colleagues, and they're analysing the relationships between social factors collected in the census and place of death, and they hope that their findings will kind of inform actions to reduce unnecessary hospital deaths and limit social inequalities in end-of-life care. And this slide just shows the cross-sectional and longitudinal sample sizes in the LS. So, for example, you can see that there are around 590,000 LS members in 2011, cross-sectionally, but of those only around 4,700 were present in 2001, were also present in 2021, i.e. kind of longitudinally, and of these only around 350,000 were present in 2001 as well, so in 3 consecutive censuses. And you can see that almost 160,000 were present for all 6 censuses spanning 50 years. But again, we need to remember these figures are provisional based on beta testing. So moving on to the Scottish longitudinal study. It was originally included in the ONS-LS, but due to a low sample size, it was withdrawn in 1991, and a new study was set up in 2007, specifically for Scotland, with census data from 1991 onwards. And it's based on 20 birth dates and includes the 4 ONS-LS ones, allowing the possibility of inclusion in the UK-wide 1% sample. And the SLS links together routinely collected administrative data for a 5.3% representative sample of the Scottish population. And the latest latest census in Scotland was delayed 1 year due to COVID. So census data in the LS include demographic, occupational, health, housing, family and social data with gender identity, sexual orientation, British Sign Language, passports held and service in the UK Armed Forces being added, being the latest additions. And vital events are added annually as for the ONS and NILS. They include births, marriages, deaths and widowhoods. In addition, that vital events, in addition to the vital events data, there's linkage to education, migration, NHS GP postcode history, and the Scottish Mental Survey. And subject to permission, NHS health data such as prescription data can be added, as well as area level data.
Jemima, just mindful that we only have a minute left.
Oh my goodness, sorry. Okay.
Do you have a lot to go? Because I also can't see any questions. If anybody has any questions, can you put them in a Q&A? Because if there aren't any, you can go on for a bit longer.
Okay. I'll carry on for a bit longer.
Carry on.
I've got about, yeah, I'll try and be quick. So the Northern Ireland longitudinal study includes 28% of the population of the Northern Ireland and approximately 50% of households. And this makes it proportionally the largest of longitudinal studies in the UK. And members are selected from 104 birthdays, which include the birthdays of the ONS, LS and the SLS. And unlike the ONS, LS and the SLS, wherein the samples are drawn from the census and data and then linked to the health registration systems to facilitate linkage to other data sources, the NILS core data are drawn from the health card registration data and then linked to the data from census returns. And the census of Northern Ireland was conducted on the same day as that of England and Wales, and the latest data was linked to NILS faster than it was for ONS-LS, meaning that the latest census updates, updated NILS has been available since last year. And this schematic, taken from a very recent paper by Larry et al., provides an overview of data available within NIL. And you can see here that census information has been linked since 1981, with vital events updated twice a year, and some vital events, namely migration and marriage, have only been included after 2001. And this schematic from the same paper shows that other data are added annually or biannually, and unlike the ONS, LS and the SLS, NILS includes environmental data, including weather and pollution, property data and school data. Thanks to Northern Ireland having combined health and social services, which share the same unique health and care identifier, data relating to the care of people in the community and admission to care facilities is linked to NILS, and linked health data in NIL and updated annually includes that from the Enhanced Prescriptions Database, the Northern Ireland Cancer Registry, the NI Registry of Self-Harm, and the NI Maternity Services System and Dental and Ophthalmic Services. The NILS, as mentioned, has been available for researchers since April 2024, and the ONS, LS and the SLS are currently in the beta testing phase, with the ONS LS to be released in autumn 2025 and the SLS in summer 2025. And yeah, that I was going to talk about the
I think
how we can support people wanting to use the ONS LS, but I can leave my side up.
So next up we have Mina talking about the latest developments on understanding society. Mina Kumari is a professor of biological and social epidemiology. She is the director of Institute for Social and Economic Research, which houses Understanding Society, and is Studies Associate Director for Health, Biomarkers and Genetics. Over to you, Mina.
Hello, everybody. Last presentation before lunch, so I'll try and get through this quickly. So, as Mari just said, I look after the health and biomarker data in Understanding Society. So I tend to focus on that a little bit in this presentation, but actually really understanding society is important for health research because there's lots and lots of social data in the data set, and so it enables you to do kind of lots of interesting research with the social and biomarker and health data that we've got available. For those of you that don't know Understanding Society, it is, I'm just going to move some of these things out of my way because I can't see them with everything else that's here with Zoom. It's a large population representative sample of the UK. It's composed of a number of different sub-components. So there's a general population sample, which is 26,000 UK households from wave one. There's an ethnic minority boost. We built on the British Household Panel Survey, which started in 1991, and then we have a set of participants that we do lots of survey methodology and development work with. We started off with nearly 40,000 households. We've subsequently added additional boosts to the data set to try and kind of keep the survey relevant to what's happening with the UK population. Let me see. There you go. So the special features of understanding society when it comes to health research is that it's longitudinal. We've got lots of data that we've collected throughout the survey on health. We've asked people things about their health again and again. We ask information from all the adults in the household. We've got the entire adult age range. We've got all of the UK countries for health, not for the biomarker data, but for the health data. We've got all the UK countries. As I mentioned, we have ethnic minority boost, and the survey is multi-topic. In terms of today, I'm going to focus a little bit on the biomarker, genetic and epigenetics, and the health and well-being. We had, I think it was eight data collections during the pandemic on COVID-19, and we've amended the survey to have COVID questions in the data set. But there's a number of different topics here. So education, employment, ethnicity and immigration, family and household, money and finances, politics, social attitudes. And we've got information from specifically focused at young people, and we have information on transport, environment. So it enables you to do health, looking at a number of different, from a multidisciplinary approach to looking at health with the data set. Focusing on health and well-being, we have data from a number of sources. So in the interview, we ask people about chronic conditions. We measure the GHQ. We have the SF12. We ask people annually about the GHQ, their GHQ and SF12. In an early wave of understanding society, waves 2 and 3, we interviewed the participants and asked them if they wanted to be visited by a nurse, and we asked about height and weight, lung function, grip strength, and we took blood samples. As Richard mentioned, for the longitudinal data sets at CLS, we also have genetic data in understanding society, and we also have epigenetic data. And we asked the participants for consent to link their data to a number of routine collections, and I'll go through that a little bit at the end if I get there. So so this is just an example of our kind of whole life approach in some ways in terms of data collection. So in the adult, we collect GHQ from the participants. We collect information about life satisfaction in a number of different domains, overall life, job, leisure time, income, health, those kinds of things. We will ask about well-being. So we administer the Edinburgh Warwick Positive Wellbeing Scale in alternate, a number of ways. We don't do everything at every wave in understanding society because we don't have the time. It's too much participant burden. From the children, we ask, aged between 10 and 14, we ask people about their happiness with different aspects of life. So schoolwork, appearance, family, friends, happiness at school, life as a whole. So you can create happiness scales from the participants. And more clinically, we every other year we will administer the strengths and difficulties questionnaire. So that you can see that we've got different age-appropriate almost measures from the participants at different ages. But this is just an example of being able to calculate or capture mental well-being across the lifespan. So that's a sort of very quick overview of where we are in terms of the history. What I wanted to do today really was to sort of promote sort of new ways that we've created data sets for you to use, where we thought there were parts of the data set that were being underused. We've repackaged data so that it makes it easier for users to use, and this is an example of one of those activities. So we want to facilitate workers, researchers who are interested in child development to use understanding society data seamlessly. So initially we had these data in lots of different places, and we realized that people might find it difficult to look at understanding society from the almost like the viewpoint of the child. So we pulled all of these data sets together. So we've got this child-based data set for you to use using a child identifier. And this means that you can use the information that we had from the parents when they were reporting from their children at age 3, 5, and 11. And then we linked that to the child's own data when they're filling out the information I just told you about, age between 10 and 14, so that you can sort of follow the data from a child-based point of view rather than yourselves having to pull data from a number of different data sources. And so we're hoping this facilitates the tracking and enables you to run these analyses. And we'll update these for users every year, so that as the children kind of come into the data set, are interviewed when they're 3, 5, parents are interviewed about them when they're 3, 5, and 8, and then they move into their own youth questionnaire, that we add them to this file so that you can kind of keep track of them as they move through. So this is the field work for understanding society. As I said, we initially started off with BHPS and incorporated BHPS into wave 3 of understanding society. In these early waves, we conducted a biomarker wave. So we have biomarkers from participants at wave 2, which was the GPS sample, and at wave 3, which was the BHPS sample. And I put this in because we are currently in field doing another biomarker wave, which will be made available in 2026. So we've got this sort of 10-11 year gap between these two waves, but we will have a new biomarker wave, which we will release at the end of next year. We will finish collection in the middle of next year. And what so here I'm just showing you what we've had to do in the interim between these two waves of understanding society, is deal with the fact that understanding society went from being a mostly face-to-face interview to being a mostly web-based interview. And so in waves 2 and 3, participants were interviewed and asked if a nurse could come to their home, which meant we could do lots of different measures. The nurse could collect height and weight and waist circumference in the way that was spoken about earlier on with the Health Survey for England, and percentage body fat and various other things, respiratory function, blood pressure, grip strength, and take a blood sample. Because wave 16 doesn't have a nurse visit, it is being delivered by interviewer or on web. We've had to do lots of development and think about what can we collect if we're going to do this. So the interviewer is going to do height and weight. We think that in our development work that a self-reported height and weight doesn't really work. It's not the same thing as doing an objective measure of height and weight from participants. And we did some work on, what do you do if you send a tape measure and ask participants to do their own weights? So We've done lots and lots of experimental work on how these things correlate with each other, and whether we can create things that will help us kind of make sense of these data. We even did some work on asking participants to collect their own blood pressures and then validated that with a nurse. And we find that it does correlate very well, although the error, the standard deviation in the self-reported blood pressures is a little bit higher than if a nurse does it. And we are also asking participants to collect their own blood samples. Within Wave 16, we're actually running a replication. So we have a nurse going into a subset of the participants to repeat the collection. So we do have this validation activity within the collection. And we'll make that available, and we'll also write that up so you can see what you need to do when you come to these data in terms of thinking about how the participant and interviewer-led collections might relate to a nurse visit. And again, because I'm the genetics, epigenetics and biomarker person in understanding society, always talk about the genetic data and the methylation data that's available in the data set. So from waves 2 and 3, we from the bloods that were collected, we have genetic data from just under 10,000 participants, and within those we have epigenetic data. So we measure something called DNA methylation from just over 3,000 participants. In Wave 16, the genetic data that we have from Waves 2 and 3 is only from our white participants, and in Wave 16 we're collecting it. We're not restricting to just we're going to expand the number of people that we have genetic data from. So we will have rising 16, so people who have become 16 at Wave 16 will be able to collect genetic data from them, which means we'll have some parent-child trios in the data set, and we'll have a wider range of people who will have genetic data from. From the methylation data, in Waves 2 and 3, we created a number of, actually I should say, as Richard said, we also do have some polygenic indices from the genetic data, not as many as are going to become available from the longitudinal studies, but those will be available from the archive, and in the actual end user license data from our data, from the methylation data, from the epigenetic data, we have created some biomarkers of age. So these things called clocks, which tell you whether you're biologically older than your chronological age. And there's a number of them made available with the data set in Understanding Society. And what we'll be doing is remeasuring methylation at Wave 16. So you'll be able to see whether how these clocks change within people, because most of the data that are available in most data sets are only available cross-sectionally. So do people who are biologically older at Waves 2 and 3 remain biologically older? Are they aging more quickly by Wave 16? So you'll be able to do those types of analyses when we come to the data, which will be released a little bit later than the main survey at the end of 2026, probably in 2027. And the other underused part of the Waves 2 and 3 data is our proteomics data. So genes make proteins, and there's lots and lots of thousands of proteins that are available in our bodies, and we've measured 184 of these proteins from the blood samples that were collected in Waves 2 and 3. And they focus on two different types of biologies: neurology and cardiometabolic functions, and enable you to think about kind of the biological underpinnings of some of the things that you're interested in when you're thinking about the sorts of things that people use our data for, this sort of how does the environment get under the skin, what are the pathways that are implicated in those processes when you're thinking about social differences in health, for example. So there's lots of these types of data that are available in Understanding Society that are available in the archive. So they're already there. So the last thing I'm going to talk about.
I was just going to say we're going into the Q&A time, but I can't actually see any questions. If anybody has any questions, can you put them in? But yes, if you're nearly there,
this is the last thing that I'm talking about, is that we have asked our participants for lots of data linkage. So we've asked them for linkage to health records, and those are the people who were consented during the COVID study, and we extended that the data will be available via the LLC because we've reconsented people in wave 14, and so we've just written some potential numbers that might be attached to the linked data that we might have. So here, and we've got lots of data forthcoming, not just for health, but for other domains, education, income, finance, and the environment, which will be forthcoming via the LLC or via the UKDS. So, the National People Database is available via UKDS, our health data available via health link data available by the LLC. I think what I'm going to do is stop and just talk a little bit about how, if you want access to the genetic data, it's through a managed process, so you have to write to us. If you the link data are available through the LLC, and I think I will stop.